Yeah,
How
my
did you?
sound's good. I have a mic here.
Yeah, it's very clear. How about mine?
Perfect. Perfect.
Great. Have you had your breakfast?
I never have breakfast.
Oh, really? Okay. So actually, I haven't really had a podcast with other guests before, so this is my first time.
No worries.
Yeah, so just bear with me. And thank you so much for being here. And it's really an honor to have you here to be the first guest. Just in case our audience doesn't know you that much, can you please just introduce yourself a little bit and what do you do?
Okay. Yeah, I'm a physiotherapist out of Toronto. I used to be a chiropractor, meaning a long time ago I went to chiropractic college, and then I just gave up my license because you don't need it here. Uh,
Okay.
I see patients mostly online, but sometimes they come to my house. It's
Really?
always weird. I used to have a clinic in my house, and then we moved. And now I have a little gym in my house in the basement and stuff like that. So there's
Hmm.
someone that wants to come next week, so they're coming in person. And I'm primarily a clinical educator. I used to be a researcher,
Yes, I know.
and my big thing is teaching biomechanics and pain science and running injuries because I think they all go together. So that's it.
Okay, great. I know your thesis is on spine biomechanics, right? It's in
Oh, my master's. Yeah,
1998,
a
right?
long
Yeah.
time ago.
Yeah, a guy like you with such a strong biomechanics background evolved after you were introduced to neuroscience, right?
S- So I did my when I was in my undergrad and then even in my master's, which was in the late 90s, it was on exercise biomechanics, like what the core does during exercise.
Yeah.
And then it was also on spine manipulation. What are the effects? And so even back then, my thesis was on the neurophysiological effects. It was all about the nervous system. And if someone Googles me and they read one of my first papers published in 2000, maybe or 2001, I don't even know. We were talking about central sensitization in that paper. I remember writing a paper in ergonomics class about phantom limb pain. So we knew these ideas back in the 90s. It just took a long time for sort of pain neuroscience to become part of physical therapy and rehab, although people were certainly saying it back then. So I'm actually really lucky. I never had to go through a lot of the upheaval in thoughts and beliefs that people had. I was influenced really young by
Mhm.
a biosocial approach. I was reading someone called John Sarno, who was writing books on how it's thoughts, beliefs, emotions driving pain. He was too extreme for me, but it's still, I was into that stuff right away. So I lucked out.
All right. So you are actually on the right track from the beginning.
Right, really lucky. And then this will surprise people. After I did my master's, I went and I
Yeah.
taught at the chiropractic college when I was a student. And the clinicians there, like Kim Ross and Dave Bresnick, who I talk about a lot, they were teaching people joints don't go out of place. Motion palpation is invalid. All of these things that people were saying, they were like, no, that's not what manipulation does. You can't be specific. It's
Yeah.
helpful, but most of the stuff that people would say about manual therapy, we were teaching people, don't worry about these things. And that's what's considered a modern approach to manual therapy. It always
Yeah.
makes me laugh because I'm like, that's what we did 27 years ago.
All right. Okay. And that's why you built up a course about reconciling biomechanics with pain science, right?
The idea there was I would give talks, honestly, 2 decades ago on myth busting and all of those
Mhm.
things. And a lot of people would appreciate it, but a big chunk would be like, okay, Greg, what the hell do we do then if we're
Yeah.
not doing these things? And I felt like there was a need there. It wasn't saying stop doing your physical skills. It was just reframing them, different ways to approach them. Right. So that's what it was there. I've always been someone, we start the course saying, what is it that needs to happen for someone to get better? Do you need to get stronger? Do you need to get looser? And what's mediating recovery? And strength is a good example. Strength doesn't seem to mediate recovery. We've been arguing that for
Yeah.
a long time. More people are saying that now. That doesn't mean exercise isn't helpful. It's just helpful for other reasons, which is better because then it means we have way more options when it comes to exercise and activity to help people. rather than doing 3 sets of 6 and just getting stronger. Right. That was the impetus for the course.
Okay. So do you think it is an important message to physios or even physios undergrad?
I think so. As definitely as a young physio, like the idea behind the course is to say, let's find your fundamentals. What are the fundamentals that you need to help people? Because if most people go on Instagram, it's where they get a lot of information, and you can really feel like an avalanche of information that's out there.
Yeah.
And you can feel like an imposter. Oh, what are these people doing? That seems so fantastic. I don't know anything about that.
Right.
Or you have scientists saying, you got to stay up to date and read all this new research. And I'm like, no, you don't. There's fundamentals that really haven't changed. And you find those and then you fine tune them. There's lots of ways to practice in an evidence-based biopsychosocial manner. Don't feel so beat up by the onslaught on social media that can make you feel dumb and like you're missing out.
All right. And I know you talk about symptom modification in the course, right?
Yeah.
And you did wrote an article on it. It was
Yeah.
in 2018, right?
Yep.
Yeah. So
Exactly.
can you briefly talk about what is symptom modification here and what can we conclude and what can we not conclude when the patient's symptom improve?
Sure. So the idea behind symptom modification goes back a step. We say, what do a lot of good therapies have in common? How can you have people in our profession who look very different and yet they're all helping people? So it could be a manual therapy like Mulligan or McKenzie or someone like Peter O'Sullivan or Shirley Sarman. And people have these different approaches. And when you look at what they're doing, let's say you lift your arm up and it hurts, and someone makes a fist, or they put their scapula in a different position, or someone puts their hand and glides the bone backwards or forward, or something like that. The idea in the past was like we're realigning the joint, we're getting the right movement patterns, we're changing muscle timing. It's very biomechanical.
Yeah.
And you can't really say that stuff. Or someone does a squat and their back hurts and they say, oh, I'm going to contract my transverse abdominis and change the stability of my spine. You can't really say those things. All you can say is, I'm doing something different. I'm changing the symptoms so that it feels better.
Yeah.
And then we repeat that and it calms down.
Right.
That's the only thing that we can say. We give someone control over their pain. Or you have a runner. And some people will argue there's a right way to run. And I would say, no, there's lots of different ways. Someone's running and their knee hurts. And we say, okay, let's change the stress on the knee or let's do something different. So this time when you run, take a shorter step or land on your forefoot. Let's change your running style a little bit. And we're not saying this is the right way to run. We're just saying this is different. It can change your symptoms and keep you doing something. So that's like just a common thread of a lot of care that we
Mhm.
simply say, let's change it up so that you can keep doing what you love. And it's really the symptoms that guide it. They're not necessarily justified. They might
Right.
be, but we can't say that.
Because I guess a lot of MSK professions say a lot of stuff to explain like why the patient's symptom reduce. And of course, most of them are making up like a story that's not proven.
Yeah, that's not necessarily harmful. I just saw a nice post this morning. It was about someone had kneecap pain, and they're
Hmm.
told, "Oh, you have knee pain because your quads are too tight."
Oh, okay.
And I'm
Yeah.
like, "Oh, tight quads are good. We want to pull on the knee." And then they get a massage and they feel better.
Okay.
That doesn't prove that their quads are too tight because
Yeah.
massage would be working for a multiple number of reasons. Because there's no way you're actually really in the short term. Yeah, they'd be slightly looser because of viscoelastic changes, but you're not like lengthening any tissue or anything like that. And even people I really like Peter O'Sullivan and the cognitive functional therapy group. I don't know if you know
Yeah.
that stuff.
Yeah.
They'll say, "Oh, your back's really tight and you're moving rigidly and bracing and guarding. So we're going to teach you to move relaxed." And I'm like, I don't think they necessarily have pain because they're guarded. Guarding is an epiphenomenon. It's because they're worried and fearful and their back hurts. the relaxation is just something they can focus on while they start to move differently again. There's nothing wrong with bracing your core because you'll have people who feel better when they brace their core and we have
Yes.
more muscle tension. So we got to be careful making these really broad, sweeping statements. So really all they're doing is let's change it. It feels better. That's symptom modification. Go, giddy up. And there's
Yeah.
lots of ways to do it.
Yeah. And 'cause recently, I've come across some approach that makes some very bold claim, like visual manipulation. I don't know if we can put it out because I've cut it out the approach, because they are like making a really big claim about the visual fascia,
Oh
and
gosh, yeah.
yeah, and they can actually change that manually, and it's causing symptoms because of the tight fascia around the organs. And I I think that kind of claim can be really harmful to a patient.
Absolutely. So I was really into fascia again 20 years ago. Fascia's funny. It comes in waves. Like the if you
Yeah,
most of the books were written 20 years ago because that's when Tom Myers and Schleep and all these people and Barral, there's someone named Barral. He talks about he's an osteopath out of France, I think. He talks about visceral manipulation and fascia. It's the
mm,
Barral Institute. So that's been around forever. But there you just have to go back to common principles like of mechanotransduction, which is how tissue responds to load. And fascia is connective tissue. We the only thing we can do with it is load it. You can pull on it. That's it. You can primarily tensile load. And if you pull on connective tissue like fascia, over time it responds by getting stiffer. It doesn't actually get looser. So none of that stuff makes any sense, like physiologically. The only way you can make fascia less stiff would be injuring it or not using it for a long time.
it's like a recent post of you, right? You mentioned about the ligament. It's just a
Yeah,
similar idea.
I love that stuff. I've been really into stretching and honestly for 2 decades of what it does. And I don't even stretch or really advocate people do, but I love the idea of what the tissue is doing. And again, that in the short term, if you do some manual therapy, you could change the stiffness of fascia or connective tissue in the short term. There are viscoelastic changes, but they don't last. And that might help some people, but it does set up this idea like, oh, my fascia's stuck and I'm having liver problems and now my shoulder
Right.
hurts because yeah,
Okay.
that's not plausible.
Okay. So symptom modification can be useful clinically, but I think we have to be very careful with our narrative or explanation to it.
Yeah, for sure. And then running with that, sometimes you want to be careful with people always trying to modify their symptoms because then they get too focused on their body, thinking I have to move this way and I can't have any pain. And sometimes a nice message is like a little bit of pain is okay.
Mhm.
Don't get too caught up in your brain thinking I got to change how I move so that it feels perfect. You're
Right.
allowed to explore and have some discomfort. So that I think that's where the skill is sometimes, or at least not necessarily skill, but the challenge is we don't always have to symptom modify. And I think for some people it can even be an issue. And then of course, if they have a negative narrative and that can really set them up to feel like they view their body as really broken and needing fixing, and that's an issue as well, just like you said.
Clinically, if we want to modify a patient's symptom, so is it like a experiment? We try and see what kind of movement or strategy that we can use, right?
Yeah, I like that terminology. That's from the psychological literature where they do exposure, and you hear CFT group use as behavioral experiments. Let's play around. Let's see what works for you.
Yeah.
Let's start doing these different movements and see how you respond. They're all on the table. Let's start trusting your body again. I like that approach. It's weird though, because I think some patients, if you ever watch like YouTube videos on
Mm-hmm.
certain clinicians, especially the ones who are very biomechanical, they're they can be very like, this is exactly how you do it. Aha, I know the answer. This is what you need to do.
Yeah.
And then then I go and I read the comments section on YouTube, and there's a huge chunk of people who are like, oh, I wish I could go see this clinician.
Yeah.
He knows exactly what to do. I need to be taken care of like that. So the problem with the way I practice in a lot of people is like that behavioral stuff where we can try different things. I think there's a subset of people who want to be told, I know exactly what to do, and they want to be taken care of. So sometimes I'm like, oh, maybe I need to be more direct, but that's not my style.
Okay. When it comes to like symptom modification, you will use a lot of it when it comes to running injury, right? Because physios usually observe their running gaits and then they correct it, try to correct it
Yeah.
as if there is a perfect or like the best running form. The first question would be like, how useful is biomechanic or biomechanical analysis in running injury? What do you think about it?
Always do it with my runners. Even online, someone this morning just sent me videos of them running. We're gonna look at it. And we do lots of it. By lots of it, I mean I always look at their running, but it's probably the least important thing, right? Changing your running style is a pain. It's not always easy, right?
Mm.
So a lot of people don't even want to. But think it's still important to do. And there are times, like I would say the vast majority of runners don't need to change how they run. You can look at their whole training, the training loads and everything going on in their life and make modifications to their training plan, do a little bit of less of speed or hills or whatever it happens to be, which is still symptom modification. It's just not
Yeah.
tweaking how they're running. And then slowly reintroduce running and exercise and all these other things that you could do. And then there's some people where we're like, they've done all those things. And so now we got to change their running, whether it's their foot strike or something like that. So it is a challenge. So we do talk about that when you would probably do it. It's usually because nothing else is working. Or if it's a simple change like cadence, people can play around with that right away. But if you're going to change foot strike, like to go to a 4-foot strike, you have to do that really cautiously because then you can introduce the risk of injury because it's a new way to run.
Okay.
But this sounds weird. I think I've done a post on this on Instagram. I also like to use running changes as a stimulus to adapt, meaning like I think trail runners do this naturally. They run on trails, which is up and down and single track and sideways, and it can make them stronger, like a stronger runner because you have a variety of loads. But I live in Toronto, and there are trails, but most people just run on the streets. And I think you can change up how you run as a stimulus for your body to make it more robust. I'll recommend that people always change up their running style, have different running styles and that's one of my fundamentals. I don't know if it's proven. I mean, it's not proven, but I still like it as an idea. We want to give a lot of variety of loads in there, and different running can do that. The other way to use running gait assessment is you're just saying, you film someone or go through and say, this is where the loads are on your body. You have pain here. And you notice how you pronate a lot. We don't need to change that. But that kind of tells us maybe we do exercises to make that a really robust, strong pattern. So instead of just doing a calf raise that's straight up and down in alignment, let's go into that pronation and really overload that. So you can use a gait assessment to be like, to almost sell your exercises. That would be the idea there as well.
All right.
So I guess to go back to your original questions, like the running assessment, you definitely don't have to always change gait. It's a small thing to do, but you can still use a running assessment for lots of other benefits.
Yeah, like selling your treatment to a patient, right?
Sure.
Yeah.
And also saying Blaise Dubois, he's at the running clinic. I used to work with them, and they like to say, hey, we've done the assessment. You run really well. This is awesome.
Okay.
Don't worry about it. Look how good it is. And you can film it and go through. This is nice. This is good. Don't worry about this. Have you been told to worry about your pronation? No, don't. This is normal.
You
Go through
reassure
it and
them.
like address any like not fears, just concerns that people might have.
Right. What if a runner who is currently in pain and who said he or she has a abnormal running pattern like knee valgus? How do you decide whether to change it or just to build tolerance to that?
So I would ask them what they thought about knee valgus. And honestly, I would say this might surprise you, but Knee valgus is not really that well linked to running injuries. It's more important that your knee hurts when we load it. And if you wanted to, but I wouldn't recommend it, you could totally try to change your knee valgus. You got to run in a mirror, you got to run with feedback, with video, and try to push your knees out or make your legs go farther. Or I would say the way we can change the loads on the knee, and one thing that often helps people with kneecap pain is just taking shorter steps,
Mhm.
which is increasing cadence. And I would say, and then I know you're worried about valgus. Guess what taking a shorter step does to valgus or hip adduction? It changes about 3 to 4 degrees. So I'm not worried about valgus, but guess what? If you take shorter steps, it's also going to change your valgus. So I would say that, but it's going to help. It can help no matter what for multiple reasons. So I'd be like, I don't want to completely dismiss them, but I'd be like, there's other things we can do. And trust me, you don't want to change your valgus. It's a pain in the ass.
Okay. All right. So it seems that you don't think there is a perfect running form for injury prevention, right? But how about performance?
Yeah. So the only thing for injury prevention, I I have biases, right? I
Uh-huh.
want to say, don't worry about your form. Go out and run, have a really good training program,
Yeah.
be healthy, eat well, sleep well, strength train, be happy, have friends. These are rest, recover, have variety in your training, have a goal race, whatever, be happy, right? Those are the most important things. But if we look at the research, there might like cadence, which is the steps you take. There's a
Mhm.
little bit of research where the number of steps you take might be associated with future injuries. It's not consistent. It's just people who take a longer stride, they and have a lower cadence relative to their height, they might be at a slightly greater risk for stress fractures. So that's like the only one where I'm like, maybe it's worth changing a little bit for people to work on because it's pretty harmless just to take shorter steps. And related to that, when you ask about performance, is there's inconsistent research where, again, cadence itself, someone with a longer stride and fewer steps per minute, they might be slightly less running economical than people who take shorter steps. There is a little bit of work where a subset of people, if they take 5 to 8 more steps per minute, they might be more, their running economy might be better. So that's what we know in terms of performance. But to, to be honest, most of the research on running economy, there are some things that are related to less running economy, like the foot being way in front of the body. But then we don't have research that shows, and the way you change that is you just take a shorter steps to increase cadence. We don't have really good research that shows if you change those things, people's performance will improve. So there's a paper by Bas van Horen. He's a great runner himself, and he's a great researcher. And he did a systematic review on all these variables related to running economy. And then he created a way to give feedback to people to change those things. And then running economy didn't change it all. So yeah. So that's it. I love the complicated research where, if anything, take 5 to 8 more steps per minute. It might help for injury and it might help for performance, and it probably won't be at all harmful. So you can just, again, like you said before, you can experiment with this if you want.
Yeah.
Yeah, I'm
So,
I'm doing a review now, not a review, like an Instagram series on running
mhm.
economy and looking at all the different ideas. And it's I've been doing it for 20 years, and it's we have ideas and then the research is so poor. Even though when you go on Instagram, it's like, oh, look at all these people saying, hey, teach you how to run better and you'll be faster. And I'm like, oh, okay, that's a load of shit.
Okay. So, other than the running form, are there any evidence-based way to improve running performance?
Oh God, yeah.
Yeah.
This is what I
What was
love
that?
about research. It's like the fundamentals from 70 years ago still hold now, which is run literally as much as you can. This is it. But I love these coaches who have been around forever because they all agree it's run as much as you can, most of it very slow, and a little bit fast. And then keep doing that for 5 years. Don't get injured. Just the more you can get, the better. And then a little bit once or twice a week is faster running. And then the icing on the cake would be strength training, right? That can improve your economy 3 to 8%, which in a 5K of someone who runs like 25 minutes, that might be 1 minute, 30 seconds to 1 minute. And then, of course, you've probably seen is the super shoes or advanced footwear technology, the foam and the plate. That all could
Mhm.
improve your economy another 3 to 8%, depending on the shoe and depending on you. That's the problem. So there you go.
Okay.
Run
So,
lots,
what a
strength
lot.
train, run fast a bit, and spend way too much money on a pair of shoes.
Okay. Okay. So let's talk about footwear. So for running injury prevention, are there any footwear that is?
So again, a really neat area. A long time ago, people still do it. They would choose a shoe to fit the foot, have all
Mhm.
these testing. That's not really well supported. And then
Yeah.
along came the idea of the comfort hypothesis. Bino Nig did this work, really a hypothesis. That's a leading idea is choose a shoe that feels good. It's not that there's a lot of research supporting that. It's just more that it's fine. Like, there's no better way to choose a shoe. And then there's a little bit of work that would say have a variety of different shoes when you run. There's one or two papers on that where you change up your shoes throughout the week. Most shoes, if it's a big bulky shoe, you can wear right away. But if you do go toward a very minimal shoe,
Mm.
you have to be very cautious when you do that. And minimal shoes almost don't even exist anymore. I still have some. You want to really ease into them. I still advocate a minimal shoe as a training effect, meaning it can make your feet stronger, right? And run once or twice a week. Or you could just do if you do a warm up, you could do your warm ups in the shoe and drills and strides and skips and hops. And that's to make the foot stronger. And then you wear your bigger advanced footwear technology
Mhm.
shoes. So that's the other way to look at shoes is like it's a stimulus, like strength training for your foot and your calf. That's my opinion on shoes. Although I was just looking it's for research on that, and the one paper I found said it didn't work, but I'm going to ignore that research study
All right.
and wait for someone else to do another one that shows it does work. I think it's still good just to strengthen your feet. Yeah,
Right.
there's a lot of people arguing that, and the feet are important for running. So yeah, do that.
Yes.
That's my footwear take.
Okay.
But in general, like with shoes, the lighter the better. For people like numbers, for every 100 grams of weight, that's 1% improvement in running economy.
Okay.
So yeah, it's crazy. So that's what's so neat with the advanced footwear technology is they're really light now. And then they also have the foam and the plate and the rocker. And so they're improving economy for a number of different reasons.
Okay. So we all know that you taught a lot of research and you're known for your critical thinking. And I want to ask you about how would you define evidence-based practice?
Uh, you know what? It's funny. I don't really even think that way about, I think evidence-based, okay, it's almost easy to say what it doesn't mean. It doesn't mean you need a research paper to do everything. I think you just need to be reflective in your practice. To me, evidence-based practice, almost to me, if that makes sense. It, I've changed. I'm less rigid in how I practice. I think there's lots of different ways for people to practice. There's many roads to Rome.
Mhm.
That's I've argued that for years in the course. And like evidence-based practice gives you a general rough guideline of what to do. It
Right.
doesn't tell you exactly what to do.
Yes.
That's evidence based practice. And it's almost like saying we might have done a lot of things for a while. And evidence-based practice will help fine tune it and say, maybe we shouldn't be doing this now. That would be the idea. But in therapy, it's tougher because a lot of the things that we do, you can argue that you should do them regardless, like exercise and activity and walking. Even if it's not the best for like hip pain or hip OA, people should still be doing that stuff. Here's an example. If you look at exercise for hip osteoarthritis, it's not that great, right?
There's a
Help
new
people.
Cochrane review on that, right?
What's that?
There's a new like Cochrane review on that.
Oh, yeah, probably. But we've seen it for a long time. But
Yeah.
I'm still going to advocate it for people because people should be active and exercise
Yes.
regardless of the pain,
Right.
right? But then at the same time, evidence-based practice to me also says manual therapy, especially in knee OA, people have said, no, it's useless. It doesn't do things. But if you actually really look at the research, it's not that bad. It's just as helpful as exercise. So I don't know, evidence-based practice to me says maybe not being as judgmental as you think. You've got to be consistent with the evidence and be open to other things. Yeah. So I'm not the best philosopher on that stuff. The way I like to view evidence-based practice in some ways is if you're critical of something, you have to be as critical as everything else, even the things that you don't like. And I don't think we really do that well in the physio world.
Yes. Like I remember you wrote a blog about exercise, right?
Yeah,
Like we don't
obviously.
criticize
Yeah.
exercise as much as other treatment.
Yeah. We don't hold it to the same standard. So an example would be ultrasound. Do you ever
Yeah.
do ultrasound on people? So,
Yeah, it's very common in Hong Kong.
so this is the thing. If you look at the research on ultrasound and patellofemoral pain, and there's no control group, people will go from 5 out of 10 to 2 to 3 out of 10. They will get better.
Hmm.
But then someone would say, oh, there's no control group. When you have a control group and you have a sham ultrasound, there's not as much difference, blah, 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 blah. And let's say, oh, ultrasound sucks. But then we'll have a research trial that will have exercise and there will be no control group. There
Yeah.
will be no sham, or it compares one type of knee exercise with another type of knee exercise. And they'll both get better. And no one will say, oh, see, exercise, we won't critique that paper as much. We'll just the systematic reviews will take both treatment arms, both groups that did exercise, and put that into the meta-analysis and say that exercise is helpful. But it rarely has a sham. And I just find that unsavory to me. That's the wrong word. Distasteful. It's an inconsistency. I'm not going to go do ultrasound, but it just means I should have some humility, I guess, in championing. I promote exercise, I bet if you have an exercise trial, there's a one for kneecap pain by Hot, where they have exercise in it and they compare it to a group that just resumes activity and had good advice. There was no difference between the groups. There's no exercise researcher out there saying, hey, everyone, stop doing exercise. But guaranteed, if it was ultrasound versus resuming meaningful activities and being active and pain science education, and then they found comparable results, they would say, hey, everyone, stop doing ultrasound. And I don't know. That doesn't seem like evidence-based practice to me.
And when the evidence is always messy and uncertain on a lot of condition, how should a clinician make decision clinically?
This is again what I think where we have options. And it's my joke is everyone says, let's do patient-centered care. And I say, what about us? What about clinician-centered care? And what I mean by that is like, sometimes there's a treatment that a clinician, I'm sure there's a term for this, a clinician really loves, you're really good at delivering, you're passionate about that. And I think that comes across to patients and they'll get better because you care about them and you care about this intervention. So it's okay to go with your bias. Or you could say, I'm gonna do the thing that has other secondary benefits as well. So I'm not sure what the person needs, what the best evidence is, but Strength training is great, even if you didn't have low back pain or knee pain or hip pain, whatever it happens to be.
Yeah.
Or manual therapies. A patient might be like, I want manual therapy. It makes me happy. I can come in here and finally relax and someone's taking care of me. And that's important to me. And they're like, okay, I can do that for your knee osteoarthritis. The research says it's close enough to everything else. Let's give it a try. As long as you're honest and ethical with people.
Right.
So lots of options is what I'm saying here.
Okay, great. So it seems like we're so free to choose whatever we want to do, right? For
Yeah.
treatment. Yeah.
As long as it's not snake oil and just completely like implausible and fully unsupported and has
Yeah,
potential risks or harm. Yeah.
great. For like busy clinicians who want to be like more evidence informed or evidence based, where can we start? Like what should we do?
So again, I don't think you need to find your fundamentals. That's it. And then you just fine tune them. You don't need to be reading papers all the time. But what I recommend is pick a topic area you don't know anything about and you want to know more. Say Achilles tendinopathy, knee osteoarthritis, and just read on that for a month or two. And remember, you've got a long career and you just do that every few months. So you might have 2 or 3 special topics in the year, and that will add up. Or a cheat I give to people is you find like a youngish researcher, he or she, I'm thinking, who am I thinking? Marie Maltebook is a researcher of stretching. And
Stretching. Okay.
yeah, what it does to tendons and muscles. Or who did I just read? She was a spine researcher.
Hmm.
Oh, what's wrong with me? I don't know. I know I'm normally really good with names.
Yeah,
Drawing a
you
blank
are.
out of Waterloo. Did it with Jack Callahan. Anyways, so it was
Okay.
on the spine and compressing pig spines and all that stuff and the damage and end plate damage and all
Yeah.
those things. And what I did is I went online and I searched for her PhD thesis, both Marie and this other person, which I'm so sorry that I'll
Okay.
think of it soon. And anyways, what I'm saying is find their PhD thesis. It'll be in a PDF.
Yeah.
And when someone writes a PhD that's 3 to 5 years on one specific topic,
Yes.
and inside that PhD thesis will be probably a 40 to 60 page research review. And so she will have done all of the work for you
Yeah.
and will have summarized the topic and go read that or download that and put it into a language learning model and have them summarize it in an infographic or slides or something like that. So that's what I recommend that people do is don't reinvent the wheel, go find a PhD thesis, and then they've done other, because when you just read a paper, you're just seeing one small research
Yes.
question. And
Yes.
the introduction and a research review it's only a couple pages. So go to their PhD. That's the pro tip.
Okay. So that's where we can know the totality of evidence on one topic, right?
Yeah, that'll give you a massive overview.
Yeah.
And then read the discussion because then they'll talk about that research. And so because they're a PhD, hopefully they're well trained in critical thinking. You'll get some critical thinking in there as well. And you can start to almost learn. PhDs are really a resource that people don't use, and they should. That's someone's life for 3 to 5 years. They really should be the expert on it.
Yeah.
And you got to take advantage of that. That's a resource.
Great.
And they're
That's
usually
a
free. You can't buy them, but they're usually online on the university's website.
that's great. That's a
Like I
great
mentioned,
tips.
sorry, I mentioned Boz von Horen. I think I downloaded Boz's PhD. I've read most of his papers, but if you go in it, it's gonna be like an amazing review of running biomechanics. I know that. Yeah.
Great. I think this has been a really meaningful conversation for me. And of course, you got a lot of things to teach in your course, right? The reconciling biomechanics with pain science and also the running resiliency. And you're coming to Hong Kong in November. So
Yeah.
yeah, for our audience, if you want to join the course, and I will put all the details below if you're watching it on YouTube. Yes, once again, I want to thank you, Greg, for giving me this opportunity to hold this podcast with you. And I really hope to see you in the coming November.
Yeah, I
Have you
can't
ever
wait.
come? Have you ever come to Hong Kong before?
No,
No?
no, just Macau.
Yeah. Have you ever? Do you know anything about Hong Kong? Like the food, the culture?
I know you're like, someone told me it's more of the future compared to Canada. Canada's living in the past.
Really?
It's more bad.
Because I haven't been to Canada, so I don't know what's like in
We're very
Canada.
provincial. I think people like to pretend like it's pretty advanced, but we're not. Hong Kong looks cool because I just know that it's a tight city, but then it's easy to get out of the city into nature, right?
Yeah,
Yeah,
yeah. We have
I
a
think
lot of
that's something.
mountains. You can go
Yeah,
hiking. You can go to the sea.
yeah,
Really
it looks
convenient.
amazing.
Yes.
What will the weather be like in November?
I don't think there will be a winter for us because this year is very hot. Because right
Okay.
now, today is 36, 37 degrees Celsius.
Woo.
Woo! It's so hot. How about in Toronto?
Oh,
What's
we're
the
like
weather like?
29. We're 29, but this is
That's
the
not that bad.
hottest it'll
Yeah.
be. It's August, obviously. But in November will be 3, 0, -5.
Oh, yeah. I don't
Yeah.
think we can get that cold in November.
Okay.
And
Good.
also, the humidity in Hong Kong is really high. It's hotter than the than 37, 36 degree because it's
Yeah, I
suffocating.
heard.
Yeah. Okay, I will wrap this up here. And I really hope this conversation can encourage physios and other clinicians to be like more critical and of course more careful about the explanation we give to patients and without making overclaims, without making them thinking themselves as broken or something wrong with their posture, biomechanics, or structure. For everyone listening, thank you again for joining us for this first episode of the podcast. If the conversation was helpful, please share it with your colleagues and your friends. And Greg, once again, thank you. It's been an honor to talk to you.
Okay, my pleasure. Thanks, everybody.